So welcome to today's webinar on healthcare reform. It's the concluding session on making it real this time. The session will feature a panel discussion chaired by Denis Vincent, exploring options and recommendations for reforming healthcare in Canada. I know he's had the opportunity to talk to Shawn Whatley, Peter Fenwick, and Ted Ball, who are the panelists, about topics we'll be discussing today, about choice in healthcare, about the options to innovate or not, primary care and leadership. But I'm not going to go any further. Denny, I've known you for a few years. I asked you if you would chair the session. I'm delighted that you joined us. I know you've had experience in the personalization process with some of the technologies that you've been looking at, and your experience as a physician. So I'll let you take it from here, Denny. Over to you.
Well, thank you very much, Perry. I'm delighted to serve as your moderator, and thank you so much for asking me. It was a pleasure to chat with our three panelists over the last week or so, and I'm sure we're going to have a nice, interesting discussion. As you know, if you had a chance to read the bios of our three speakers, our three panelists, Peter Fenwick, Ted Ball, and Shawn Whatley, these are all people who are passionate about the healthcare system, healthcare reform, and each coming from a different angle as well. So it's the way I hope to proceed with the discussion today is that I will raise some questions and then have them each in turn talk freely about any insights, any solutions that they can come up with. So when I did have a chat in a review to I wasn't able to attend the last two webinars, but I did review them. I did listen to them afterwards. There were four themes that came up. One was innovation, choice, primary care, and leadership. So I will ask our panelists to riff on those four themes here. And but before we get started, I would like to ask our panelists to introduce themselves and to recount one quick personal anecdote, maybe about a person they know, an event that happened that exemplifies in their mind our need for healthcare reform. So I'll ask Ted, maybe, can you tell us about a quick little story about, what spurs you on and talking about healthcare reform?
Well, so I was going to do a personal anecdote because I just had open heart surgery and it was just wonderful. And then I had this rehab that was extraordinary. So I was going to say some really positive things. You just turned it around just there. I'd like to drop that one and say rather, I'm working with a group of about, there are now 1 million patients suffering from environmentally linked illnesses who are not recognized. These are people with myalgia, encephalitis, long COVID, multiple chemical sensitivity, fibromyalgia, and a couple of others. And there's 1 million patients that don't get any treatment because conventional medicine can't grasp the complexity. And when conventional medicine doesn't get it, the College of Physicians and Surgeons doesn't get it, and therefore the bureaucrats don't feel comfortable. And therefore we got 1 million people in Ontario suffering from environmentally linked illnesses that can't get treatment, have been fighting for 30 years and can't get recognized. So okay. I think that's kind of that's a whole group of people. It's quite considerable amount of people as well.
Okay, well, thank you, Ted. Peter, would you like to share an anecdote of something recent in your experience in life?
Well, so the context is what's the impetus, and perhaps as an individual, what was the impetus to get involved with not just maintaining the status quo? So if you think about reform in the context of making something measurably better, there's I think for many of us, perhaps there's been a drive internally to make things measurably better, largely because you're like, this can't possibly be the end state, right? Okay. As I love that Ted's bringing up the patient-centered focus to things. I'm involved in a number of organizations right now, which is really community and individual focused, as opposed to system, working on the fringe in order to try and influence the system at whole. But I was going to start by saying, when I was inside the Alberta health system proper, got very, very frustrated about 10 years ago on the inability for us to get beyond pilot projects. And I think Canada at large has the same challenge. But I think what I'm going to focus on is, I'm fortunate that I've been able to travel to probably 25 countries around the world, and at least half of them I've had a chance to study the healthcare system, from primary care to long-term care to government. And it's what helped me think about what innovation actually means, which is not necessarily reinventing the wheel, but it's studying what other people have done and asking the question, why can't we do it here?
Yeah.
And it's when I came back from leading an envoy to Intermountain Healthcare, Utah in 2013, with a group of senior leaders from Alberta with a mandate to think about how to replicate aspects of Intermountain's fantastic model in Alberta, and then having the Minister of Health fire the board chair, interfere in governance, overstep, and find a way to actually shut down many of the things that were attempting to be done, that completely outraged me and a lot of other people. But then the question is, what are you going to do about it?
Yeah. Okay, thanks. Shawn.
So you asked about an anecdote, and this is one that really came home to me. So I had a gentleman, and I call him a gentleman because he was a man. He was gentle. He's actually passed away since the story occurred. He had recently retired, and he had a few minor medical illnesses, really nothing to speak of, but just a very nice, soft-spoken, intelligent, experienced, retired executive. And you could just see, sparkle in his eyes. There was a lot going on that he didn't say. And so right away, the clinicians in the rooms are hearing me, and they're saying, oh, countertransference reaction. Whatley probably had a connection with this guy and thought he was his uncle or something. But it's true. I really did like this guy. And I do like most of my patients in that way. Just they're wonderful people. So this fellow came in and just coughed. And if I'm going too long, he came in and he was profoundly dehydrated. So pale, weak. He walked into my office. And I said, my goodness, like you look terrible. His blood pressure was low. I sent him to Emerge. He went there with a family member. He got rehydrated, spent a few days actually in the hallway. It's because there were no beds. He got admitted, but admitted to a hallway, and then was sent home. And so I have him back in my office. So he's rehydrated, back to his old self. And I had done a ton of innovation at the Emerge that he was in. And so we had the lowest wait times in the province. Some of the lowest wait times, I'm pretty sure the lowest wait time to see a physician in the whole country. I was very proud of this because I had been very embarrassed of it before. And so I was, how was your time in Emerge? Doc, it was great. It was great. Did you wait long? No, I didn't wait at all, Doc. It was great. How were the nurses? Doc, they were fantastic. I'm so grateful. Do you feel better? I feel great now, Doc. How were the doctors? They were great too. And he paused. So I paused. He obviously has something else he wants to say. So just like Ted, right? Very positive. Everything went great. Typical Canadian. I'm so thankful. And then I said, is there something else? Or maybe I just leaned in. I don't even know if I said anything. And he said, well, Doc, everyone was so nice. I really hate to say this, Doc, but I was sitting in the hallway on a stretcher in a gown, naked, with a gown and a sheet. And Doc, I had to go pee. And the railing on my stretcher's up, and I'm hooked up to an IV. And it's busy, but these people were so busy, Doc. They work so hard. Boy, they give great care. He did not want to complain. Make a long story short, he got someone's attention. They come over. He said very sheepishly, this is a no stroke, corpus mentis, very intelligent guy, ton of world experience. And he whispers, I need to go to the bathroom. I need to go pee because his IV is working, right? He's well hydrated now. His kidneys are creating urine. And the person stopped, looked at him, looked down and said, you have a diaper. And they kept running. And he paused. He didn't start bawling or anything, but he was pretty close to tears. And he said, you know, Doc, I get it. They're busy. He said, but it's just the indignity of it all. And so that story hit me, not because it was a moving story. It hit me because in that very same department that I had done so many renovations in, and so much change in our wait times, and so much improvement. And we actually got an award from the Minister of Health for the work we were doing. I wrote a book about it. Like, I was really proud of all this. And yet I was blind to this cultural norm of saying, you have a diaper. And when he said it, I had heard it, you know, dozens of times every shift. Usually you even say, well, do you have to go number 1 or number 2? Number 2, you don't want to have happening in the hallway because it's messy and smelly and it's way more work in the long run. You might as well, oh, okay, we'll drag you to the bathroom. But number 2, so imagine anyone on this call right now, you've never worn a diaper since you were a child. And now someone's thrown a diaper on you and they're telling you you've got a diaper, and just, you know, it's wet, it's smelly, you're there, it's in a public place. And so the indignity of it, and it took, you know, what, 25, 30 years of practice of being involved in medical industry, for that really to hit home. And so that's kind of the anecdote that I use that really shapes my view on why we need to change. That should be a never event.
Yeah. Oh, thank you. Thank you. Well, now I guess we'll touch on the 4 themes that came out of our discussions and from the previous webinar. So I'll start with innovation. So everyone agreed that innovation should come from the bottom up. That was clear from our chats. Frontline caregivers understand patients' needs better. They understand the barriers and are much more open to patient co-design. Problem is our healthcare system is risk averse. And yet innovation requires learning from mistakes. If we are not allowed to make mistakes, how can we ever find new solutions? Even worse, the frontline worker, as it stands today, is afraid of being blamed for bad outcomes. So it's just easier to follow the protocol and shut up. Most who try to innovate soon give up. So question, how do we encourage and reward innovation? How do we rekindle a genuine spirit of innovation? I'll start with Peter.
So Peter Drucker, of course, said what gets measured gets managed. And if nobody has thinking differently to better create value for the patient, for their peers, for themselves, for a community, as part of their job description, then nothing changes. And that gets to the core of the business model, and whether that business model is as a broader public sector agency like the hospital that Shawn was describing, or that business model is an integrated health authority like the one I used to be head of innovation for. Major initiatives was effectively working with and collaborating with clinical enterprise, non-clinical enterprise, and looking at ways and means of improving patient care, health outcomes, patient experience, the triple aim, as well as looking at better cost and value for money. If it's not being measured, it's not going to get managed. And 2 weeks ago, I made a comment regarding the fact that I think the biggest, and this is me speaking as an engineer, the challenge that we have in the system is that we are completely lacking in measurement. And electronic health records, even the $2 billion that Alberta spent on Epic for Connect Care, once it's fully deployed and fully costed, is still not looking at things like activity-based costing. We do not know exactly what things are. And case costing, I'm sorry, is not the same. Looking at averages is not the same as looking at variability. But to get back to, kind of what fosters innovation at the beginning, you have to believe in the creativity of individuals. If you believe that everybody is born creative and the public school system beats it out of you in conformity in order to make rote work, which has been widely studied, then you think, okay, when I graduate from whatever degree that I have, how am I being taught how to think differently, to challenge the way things are, and to not necessarily invent, but to at least try things. It's okay for things to not work. Now, obviously, we don't want people to lose their lives. That's the whole point of coming into the system when you're not well, but to improve things. But there's a few basic, I would say almost there's a bit of a flaw in the way you phrased the beginning, Denis, because I'd say there's one party who's better understanding of the patient's needs other than the front line. And that's the patient themselves.
Yep.
Right? So we don't often have the habits in place. And innovating would be to apply customer service mindset to the healthcare system, where we don't need to think about whether they have a willingness to pay, whether it's their wallet or not, whether it's the tax dollar that's broadly sprinkled across the public. But if the individual had the choice, and we'll get to that later, to judge based on quality and cost, would it matter? Right? Would it matter? And so believe in the inherent creativity of everybody. The spirit of innovation, I think, was really nudged on, and I'll do the Tommy Douglas quote now. I shared this story a few weeks ago, so I'll repeat it just for the sake of the people that might be watching the new recording. When I was working with the city of Airdrie to establish the health cooperative that was about integrated and interdependent primary care, I pitched to a group of social impact investors, and one of them stood up. This is a national audience. One of them stood up and he said, "I knew Tommy Douglas." And he said, I'm from Saskatchewan. My father was his driver when he came back from Ottawa. And he used to kick my ass out of bed every Saturday morning. And we would talk before they went off and visited the community. And I've listened to your pitch about why this innovative model that is not new to Canada, health cooperatives are not new to Canada, but at the scale we were talking about, at a community of 62,000 people, it was innovative. It was maybe novel. But the point is, Douglas would have said the same thing. Bob said this. He would have said the same thing now as he would have said in the 60s. Healthcare is broken. Go fix it. Do something. So you have to believe in your heart of hearts that you can make an individual difference and that you can rally, and that you have an accountability and a responsibility as a citizen to do something about it.
Great. Thank you, Peter. Who I've got next? Shawn. Innovation.
Innovation, I believe, comes from the bottom up. Innovation is crushed from the top down.
Yep.
So my staff in my clinic, for example, if they come up with a solution to a missed appointment, or someone was no-show or whatever, and they apply creativity to solve the problem, call the person, call a cell phone, call their neighbor, go to the person's house, whatever, right? They care for these people in our community. And I come to the front and go, "You did what? How could you be so stupid? Why didn't you talk to me first?" So there are 1,000 ways for me to crush their sense of ownership, to crush their sense of innovation, to crush their creativity. And next time a problem comes up, how are they going to face that problem? They're going to say, "Well, I could do this or that, but you know what? It's Whatley's clinic. Let him take care of it." And so when we multiply that situation by 320,000 clinical visits per day in Ontario 5 years ago, so we're talking, I don't know, 1 million visits per day in Canada, interactions, whether it's in the lab or the X-ray suite or wherever, you have just a wealth of opportunity to innovate and to improve service. And it only takes one moment to crush that spirit of creativity and innovation that required years for me to build. And so I won't say more than that. I'll stop there. And actually, I had one more comment. We must be extremely careful of putting our, Matthew Arnold put it this way, a superstitious faith in machinery. And machinery, he was talking about managerial technique. Michael Oakeshott in his Rationalism in Politics, great book, fantastic essay. He talks about the supremacy of technique. So those of us who love Drucker, I love Drucker, and I love Peter too. I love reading management experts. I have got a whole shelf full of management stuff. The risk when we apply our love of management to healthcare is we fall in love with machines. We fall in love with techniques, and we start to put our faith in the supremacy of technique. And Perry probably knows a lot about this too in his business background. So there's, yes, we need measurement. Yes, we need good governance, but that's not the whole solution. We also need that vital spark that only exists at the front. And we've crushed that in the name of safety, protocol, procedure.
Shawn,
Thanks.
is that a yes and as opposed to a binary either or that you've just framed it?
It's either or. I'm right and you're wrong.
Hmm.
No, of course, yes, and of
Okay.
course.
Thank you, Shawn. Ted, what can we do to rekindle innovation?
Well, we've got a lot of work to do because, and I think it's being acknowledged here, certainly just by Shawn just now, that, and what I know for a fact is that the answers to our most complex, perplexing problems in healthcare are in the hearts and minds of the people in the system, the frontline care workers. I know that for a fact because I worked with, for 20 years with a group out of Austin, Texas, facilitating the collective intelligence of doctors, nurses, and frontline care providers who absolutely knew what the problems were and could generate the examples. They didn't know they knew the answers. They discovered it in a process of facilitation using techniques for collective intelligence. And so we could extract that out, but it wasn't, you had to extract it out painfully because they live inside a culture of command and control, and they live in a culture of fear and anxiety. Now, when you're walking around in a culture of fear and anxiety, and I think, Shawn, you just said, being blamed, or someone said being blamed, that's precisely it. It's not about accountability, which is perfectly appropriate, but accountability has become blaming. Who gets to blame who for what? So in an atmosphere of fear and anxiety, and people being self-protective, blame avoidance oriented, then you're stifled. You are not. And what we need to do is liberate frontline workers with methodologies. But we're talking about changing the culture of organizations that are ingrained with command and control, that the CEOs and senior team and managers enjoy and love the command and control that they possess. They admire the structures of blame rather than accountability, for best practice accountability, and they create the cultures that makes it impossible to allow that brilliance to come out of the system. The brilliance is there, the answers are there, but we got to fix the culture of command and control.
So Denny, I'm going to interrupt with a point that I made, and I present this to each of you. The culture was built on an ethic of thou shalt do no harm. Is that ethic not in conflict with trying something different?
Is that, sorry, Terry, is you're quoting an element of the Hippocratic Oath, and a few of our, I mean, Denny and Shawn have, of course, sworn to that at one point in their career. The history of Hippocrates, though, you know about Hippocrates as the teacher, what that really meant?
I'm hoping to get to the answer to my question,
Well,
whether or not innovation is in conflict with an oath that says that it's not going to do any harm. That's
Well,
what Health Canada threw out at me when we talked about trying to find out whether stem cells could make a difference. And their argument was, because there's the potential of harm, let's not do anything.
Well, it's often the case, what works at the micro level with the patient in front of me, I certainly don't want to do any harm, and we'd have to have that discussion, but it's a matter of a conversation with this particular individual. But if we apply the Hippocratic Oath to society at large, that's a different kind of story here. We can't often apply the rule at a micro level to the macro level. It doesn't make sense. So I think that's a common logical fallacy that people make.
I think that needs to be addressed.
Yeah.
Okay, you're on
Next theme. Yeah. Thank you everybody for those insights there. Choice. Think about, I know Perry, believes strong in personalized medicine, and of course, patients want choices. Patients right now often have no choice. They're corralled into one line, and that's the lane you're going to wait for your turn. But everyone likes to have choices, and that's when we feel we're empowered. But meaningful choice suggests that there should be some healthy competition, really. Competition between hospitals, competition between practitioners, between clinics, between services, between different types of professions, in fact. Problem is that there's a recent tendency towards uniform service. At least in Alberta, single point of access, central unified intake systems for the sake of efficiency. Yet, I think a monopoly can't compete with itself. And the result is a substandard of care for everybody. The other problem is that there's an aversion to letting private agencies onto the landscape. Yet private entrepreneurs are keen to provide a competitive edge to their product and a unique offering, and hence more choices. So I guess, without these providers, without compromising standards of care, they can compete on other factors. They can compete on the basis of offering unique patient experiences, focusing on special clienteles, or offer other ancillary services that the patient may want. So question, how do we balance maintaining standards of care, yet encourage healthy competition and more choices for the patient? This time I'll start with Shawn.
Sure, thanks, Denis. And that's another gigantic question. And it kind of weaves in what Perry said just now, right? How do you promise to not hurt people, but yet make space to try new things? And so you're overlapping intention versus known outcomes and regulation. So I'll answer your question, though, with a specific example. So really you're asking about, oh, where did you go? Now you're in my top right corner. There you are. So how do you get clinicians to change? So I'll focus your question in on how can you get people to change and to try a different service model, which by definition would create different service than a hospital across the street or across town, which would then lead to competition, right? The patients would say, hey, I can go to Denis Hospital or I can go to Peter's Hospital, and how am I going to choose? And so we went through that process actually in Ontario for the last 10 years with pay for performance in emergency medicine. And as I believe Ted was saying, and perhaps Perry as well, that our whole approach to healthcare is very resistant to change, and rightly so, right? This isn't because people are evil. It's because we have lots of rules that have been put in place to keep people safe and to give better care, higher quality care. So the way we approached it in our Emerge, and basically we turned our process upside down. We closed the waiting room, brought people right in, got rid of 6-page nursing assessments, went down to 1-page nursing assessments, didn't even have a nursing assessment. If the physician was ready to see the patient, get the physician and the patient together, see them, send them home, treat them right away. If we don't have a stretcher, it doesn't matter. You're sitting in a chair in the waiting room, you can sit in a chair inside and we'll treat you in a chair if we have to, if that's all the hospital's given us. And the way we made those changes wasn't by saying, oh, we should treat people in chairs. That's not what we did. We started by asking our colleagues, number one, why did you go into this job? Did you go into this job because you wanted to have people having their miscarriages in the waiting room, bathroom? Did you go into this job because you wanted your next door neighbor sitting beside 3 other people that were vomiting in a bucket? You guys have been in waiting rooms. You know this happens all the time. People passing out on the floor, people literally dying in the waiting rooms in hospitals across our country. So we started with that. Is this what you wanted to do? Is this the career you wanted? Everybody said no. And then we went through a number of steps, but the one thing that I think really was the crux of it is we asked people, how do we treat our most privileged patients in the Emerge? And they said, oh, well, we treat everybody the same. I said, no, we don't. If I bring in my kid, I walk up to Denis and say, Denis, my kid's got a sore ear, look at it, right? I had a red eye once. Someone said, Shawn, your eye's red. I said, no kidding. I went over to Eugene. He's an ophthalmologist. So he's actually a subspecialist ophthalmologist, happened to be in the department. I said, Eugene, look at my eye. He said, oh my gosh, I should look at that. Go sit in front of the microscope. So in about 30 seconds, I had consult, referral, assessment, and about 90 seconds later, I had treatment. My eye was feeling better. I had a bit of iritis. I'm a privileged patient. The nurses are privileged patients. Their families are privileged patients. And so we started by saying, if we can give that kind of care to our most privileged patients, patients who we know and love, and we can break all sorts of rules. We don't do secondary assessments, and we don't do full vitals for someone who just has a sore eyeball or a sore ear. Then why can't we start being a little creative with what we do for everybody? Because what everybody needs is treatment. The biggest predictor of survival is getting your antibiotics if you have meningitis, not having multiple assessments with 6 pages of notes and multiple vital signs. No, you need your antibiotics as fast as possible or you die. And so that's how we did it in our department. Now, it was swimming upstream. We had to fight pretty much every other department in the hospital. We had to fight the service union. We had to fight the nurses union. But when you got really down to the hearts and minds of the people who were there, who were caring for each other, for their own friends and family, and said, this is what we can do for the people that we really value. Why can't we do this for everybody? Then you just sort of open all these floodgates of creativity and say, oh yeah, okay, well, let's not do that. Yeah, no, let's not leave everybody in the waiting room. Yeah, let's bring everybody in. Now it takes 3 to 5 years to bake in that cultural change, and then another 5 to 10 years to make sure it sticks. But you can do it. You can have competition. Our patient volumes went up by about 25% in the first year because word got out, oh, the shortest wait times in the region, drive down from Barrie. It doesn't matter if it's an hour and a half drive, get down there. You'll still be seen faster than if you go to the local hospital. But that 25% jump actually leveled off, and we continued to grow at our normal background weight. So it's possible, it's there. It gets back to innovation from the ground up, but you have to start with hearts and minds. And it's almost like you have to do a couple of years of psychotherapy for the people who are in the department to try to get them to be willing to trust and try something new and to try a process change. Okay, we'll move the chairs over there. It's okay if we do that. No one's going to die. And so that's what we did. But so much more that you could say on that question. It's a huge question for sure.
Thank you, Shawn. That's good. Ted, do you have any insights on patient choice?
Well, so I see it as a major issue of system design, right? And if we take a look at the macro system design, and our problem is many of our designers who are currently there are ideologically driven rather than understanding systems, rather than having any discipline of systems thinking, or the science and art of system design, complex adaptive system design, which is what healthcare systems are. Back in my day, when I was working for the Bill Davis government, there was a real belief is that we needed certain safety valves or pressure valves in the system. So we would bring in private sector people, say in nursing homes or in labs. And it was really great because what they did is they kept the public sector in check on price, right? So you'd bring in, and on quality. Today, however, so we had a mixed system with a little bit of private sector participation offering choice and mostly competition and keeping the public sector more honest. Today, under the Ford government, they have a much stronger ideological commitment, kind of a belief that private sector and for-profit is somehow going to do us some good. Whereas I don't see it that way. I think that what we are now seeing in Ontario is that in the instances that they've done, we have less quality and higher costs. So, for example, in the nursing home sector, we go to big companies like Southbridge Long-Term Care. Southbridge Long-Term Care, you probably read about them in the newspaper when the army came in and took over their nursing home and dragged out hundreds of bodies and found rats and all kinds of other horrible things. The write-ups are absolutely terrible. They have now been signed on to a 30-year contract ironclad 30-year contract into the future. And so that's when that's the misuse of choice. We want private sector providers. We want choice. That's good for all of us. So I think it's about designing systems with safety valves in the places where we need them. And Shawn, you might recall at one point in Ontario, we had the option of opting out and extra billing, right? Which was a safety valve. In other words, you can't have a good healthcare system if you don't have happy doctors. But you can't have them hold them in handcuffs. You need to liberate them. So what we had was a safety valve called that you could opt out an extra bill, but that was a choice that you would make, and if you could survive, go ahead. But unfortunately, I think we're too driven by ideology and beliefs and not by the pragmatism of having a mixed system where there's choice as well as the public sector providers.
Thank you, Ted. Peter.
These
Any-
are action-packed questions.
Yeah.
And I guess I first want to compliment Shawn on his application of management science into the emergency room of his facility. I think I love the experimentation and the empowerment and acknowledging that two-tier medicine actually does exist in Canada. When I was inside of Alberta Health Services, I had the opportunity to lead the province's response to the inappropriate access to patient care inquiry. And it became clear in spades how many different policy level and practical changes needed to be made in order to ensure that there, that those types of things, those things are going to happen. They're going to happen in any system, in any social system, and the healthcare work environment is a social system. The point is more to do with what are we learning from that, and how are we breaking down barriers that don't need to be there just because they've always been there. The other piece is, I think some of the healthcare systems that are better at translating bench to bedside to community gains of less than 20 years do apply a better rigor of measurement and feedback loops. And I'll give you a practical example here in Alberta with the Alberta Bone and Joint Health Institute, which somehow managed to take, under strong physician leadership, managed to take every single orthopedic surgeon in the province and give them a scorecard once a quarter on how their patient outcomes were. And that helped them challenge their teams that they work with, the rehab that they work with, and interacting and engaging with primary care, so that it was about comparability. Mm-hmm. And so choice is relevant or relative to what you're speaking of. I think it's important for patients to have choice as long as they believe they have agency in that choice. Right now, they don't. Right? There's such a shortage of primary care doctors, as you know. There is no choice. Right? You're lucky. My primary care person, by the way, is my chiropractor, who does a wonderful job of asking me when I come in, the last time you were here, you saw me about this. Your life goals were X. You had these issues. How are they now? How have your goals actually changed? And what can I help you with today? And it'd be wonderful if every healthcare provider on every exchange just didn't treat symptoms. So choice does have a lot to do with that engagement and that experience. But transparency is one of those themes that I wanted to bring up, Denis, because when we look at transparency and how that influences choice at the front line, that also has an issue with how we look at transparency and choice at a systems level. Ted spoke about complex adaptive systems. We have a habit in Canada of only looking at healthcare as what the public funds, as opposed to what the person funds. And if you're employed, you pay into 3 different health insurance schemes. What the province provides is only one. What your third-party health and dental benefits provides is a second. And the third parallel healthcare system is workplace safety, which jumps queue constantly in order to get you back to work. Why? Because society values you more at work than being injured at home. And we jump queue in order to do that. So that's one element of looking at how things are paid is the insurance bit. The other is actually competing on outcomes. And many of you will remember, and I remember this because I started and led the public-private partnership team for hospitals at GE Healthcare when I was there, is we looked at outsourcing in 30-year contracts, the non-clinical facilities-based care of design, build, maintain, operate hospitals, jails, ring roads, and schools. And the whole point was we didn't think that a publicly led and publicly financed initiative could be anything but over budget, out of scope, and not on time. And the risk was offset to the private sector in order to allow for any kind of meaningful improvements. Now, that didn't always happen because guess what? Those in charge in the public hospitals constantly made changes, which is why William Osler Hospital was a 15% cost overrun. Where this is happening with a good positive example, I'd say, and I learned this directly from the former, I think maybe he was Auditor General or Cabinet Secretary of New South Wales, Australia, is actually a wonderful example in the corrections world, where and his name is Gary Sturgis. He wrote some wonderful work on their bits on contestability. In Ontario and Alberta, we have the Auditor General come in and do value for money audits on services. In the New South Wales, they started down the path of looking at public-private partnerships. And then what happened is that the scorecarding and the metrics of decreased recidivism, right? People not going back to jail because they actually got reformed and supported as they were going through their correctional facility, not just staying in there. The public sector, the ones that were running the publicly run jails, went to government at the next time the PPP was let to market and said, hey, can we put in a bid too? And so the overall bar raised because the private sector was leveraged to improve the performance standards measurably, right? The public sector then said, we will lose business. The unions will lose business if they don't change the way that they do things to be measured in the same way. And so this whole element of contestability and comparability raised the bar. We tried doing that in Alberta with the Southern Alberta Eye Institute and Rocky View. But what happened was AHS refused to put in the underlying cost structures on a per case basis, whereas the private institute had to. And guess where the business went? Lack of transparency, not proper contestability. Now, take that for what it is, but there's lots of business model innovation that can be applied to better impact patient care, patient choice.
That's good. Thank you, everyone, for that. Our next theme: primary care. So, as a family doctor, I guess this is near and dear to my heart, and my apologies to Dr. Turner because I might say something you might not like. But anyways, everyone agrees that primary care is in crisis, and yet it should be the backbone of a successful healthcare system. Primary care is where preventive care and lifestyle education should happen. This is where personalized care starts because the patient we know is an actual individual, it's a person we know and a person we dialogue with. And this is where choices can be made. The patient's not a number in the family doctor's office, should not be a number in the family doctor's office. Rapid access to family doctors is well known to result in early diagnosis and early intervention. Robust primary care offloads emergency wards and reduces hospital sick care. The problem is that the public and politicians focus on two main things when it comes to healthcare. Number one, cancer care. And ever since President Nixon declared the war on cancer in 1971, it has captured the public's imagination like landing on the moon. The curing cancer has been, it's front and foremost in most people's minds when we think of healthcare. And arguably, disproportionate amounts of money are spent on cancer research, sick patient treatment, but yet there's lots of tremendous success stories in that area as well. So it's not an either or issue. But no one does any major fundraising for primary care, for mental health, for affordable housing, for early childhood preventive care. And it's very hard for these sectors to compete for attention. And the other problem is wait lists, and they're tragically real. Now in Alberta, you're looking at 2-year waits for hip replacements. And, even 10 years ago, that wasn't the case. It's just gotten worse. And I just feel that we're not going to be able to address meaningful healthcare reform without fixing this wait list issue, because that's what people want fixed now. So I guess my question to our panelists is, how do we redirect the focus onto building a robust primary care ecosystem? And I'm not saying system, I'm saying ecosystem. So I'll start with Ted this time.
Thank you. So again, on the issue of system design, every system is perfectly designed to achieve the outcomes it produces. So in Ontario, no, actually, this is a Canadian figure. We kill 25,000 people annually in our hospitals, called preventable accidents. The system's designed to do that. In Ontario, we have a 40-month waiting list for children's mental health services. This is, for cases where, the kid comes to the parents and says, I'd really like to kill myself. If they had a broken ankle, we could bring him down to the hospital and he'd be in a cast. But if he wants to kill himself, he has to sit on the bench for 40 months waiting for a mental health professional to be available. We have 2 million people who don't have access to a primary care physician. We designed the system this way. How did it get designed this way? Well, I write very annoying posts on LinkedIn where I call the Ministry of Health the Ministry for Hospitals. They're not the Ministry of Health. They don't think of primary care. We have designed the system without paying attention to the backbone to the system, which is strange because in a political system, which it is, the number one issue for patients is their doctor. If 2 million people who don't have access to a doctor, this is key. And so how are we going to fix that? In Ontario, I'm not sure about the circumstances in Alberta, we need a lot more nurse practitioner led clinics. We need more CHCs, community health centers. And we need to we need to train more physicians and get more physicians. So here we are, we're spending in Ontario, $81 billion a year and producing outcomes that are just totally unsatisfying to the public. So if we want to fix primary care, we've got to push all those buttons and change the design of the system. And hopefully politicians and bureaucrats will understand that that's the most important thing to the public who owns the system, right? It's the public that owns the system and pay the taxes to keep it going.
Thank you, Ted. Who am I going to list them in? Oh, Peter's next on my list. Primary care.
So there's been a tremendous amount of primary care ecosystem experimentation. If you think about, you even go back, gosh, Denis, when was it? Was it less than 15 years ago that primary care networks were put in place?
Yes. Yeah. About 15 years ago.
Which were about taking a look at allied health integration and bring a fractional resource to primary care clinics for things that weren't obviously done as a solo practitioner or even as a group practice. Crowfoot Medical in Calgary, of course, is about 30,000 patients under coverage. They are the only globally funded, 90% of what they provide is globally funded, nurse practitioner led. You only see a family physician when you absolutely need to. And they have accountability for getting their patients out of acute care, discharged back to community quickly. And it's the only clinic of its existence. And it's been around for over 20 years, funded on 3-year rolling envelopes. They manage the health of the population by looking at integrated and interdependent primary care. is an ecosystem within the clinic. Yet for some reason that's never been scaled. Right? Fascinating. So the question about building, you know, how do we redirect focus on building a robust primary care ecosystem? These examples of where ecosystems already exist, they're there in Canada, they're there in Alberta. And what's happening is that they're not being scaled, right? I also want to make sure I acknowledge, and one of the things that I'm happy to have done earlier in my career is spend a lot of time in southern, remote, rural Alberta, everywhere from Crow's Nest Pass to Milk River. And one of the things that I remember from visiting Milk River was primary care was the emergency room. Primary care is where you went, or the emerge room is where you went to see your primary care doc, because the retired person that came back out of retirement to serve in the Milk River, she was there because she knew that nobody else was coming down there. So when you look at primary care, and I've just used examples for what's publicly reimbursed. We have, of course, in the last number of years with the advent of virtual care, which, remind you, started before the pandemic, was accelerated during the pandemic. Employers stepped forward in spades to support the scaling of virtual primary care, right? There are companies like Dialogue out of Montreal that are doing a version of that. I won't get into Babylon because it's a little sensitive here in Alberta with their payment models. But I like where you're going with the idea of integrated and interdependent. The quick story that I'll tell around Airdrie and the health cooperative is that we had 25 out of 35 primary care physicians bought into a social contract of getting off of fee-for-service. We were walking the path with the AMA to find a way to look at a salary-based model so that physicians could focus on care, not administration, could be rewarded and basically rewarded for applying their mastery, their autonomy, and their purpose, and being really engaged in patient care. But the politics of the existing system came in and put a stop to it. Why? I think Ted said it best. The system is currently designed with a top-down, pejorative, power and control way of doing things. And any kind of shift in power, which is probably your next topic of leadership and whether leadership should be distributed more than it currently is. Short answer, yes. If people don't believe that their way, if people can't get beyond their way being the right way, change is not going to happen with the current players in the ecosystem.
I personally experienced, I was on the executive of our primary care network at the start. And we were encouraged to, be responsive to our local patients. There was, local control for local needs, and it was fun. It was fun, and we were actually making some good headway. Some PCNs were more successful than others, and that often had to do more with what resources were available. But things started to shift. Then we had AHS representative who come sit at our meetings all the time, and oh no, you can't do this or you can't do that, and they started to flatten the landscape, make sure that nobody's offering too much more than the others, because that wouldn't be fair, and it switched. So now there's much less of this local control of PCN. Now we're using PCNs to implement initiatives.
If I know how we're doing on time, Denis, but I would offer one more thing, only because the current Minister of Health has it in her mandate letter from the Premier to look at decentralization of decision-making inside of Alberta Health Services. And the article that came forward from Tom Noseworthy and Braden Manns, albeit argumentative about blowing up AHS is not the right answer, they missed the point. That's not what it says in the mandate letter. What it says is allow local leadership to occur. Not to dismantle a system that has some benefit to centralized model of some things and decentralized of others.
Peter, I need to step in here. Decentralization, like zero-based budgeting, like downsizing, all of these are about resources. Nobody's talking about the patient. The union's perspective, as Shawn pointed out earlier, that got in the way of some of the choice which he wanted to make available. It was the union got in the way, and yet the physicians are members of that union.
Mhm.
In a public sector system, the discussion in the legislature is about jobs and about budget. Nobody gets into a discussion, although it might be incidental, about waiting lists or whether the patient is getting service. Decentralization alone is not an answer. They have to decentralize for a reason that is going to change the welfare of and the outcomes of the patient. That's what I want to hear about.
Yeah. So own your own health was the theme of the Airdrie Health Cooperative. It was started by the citizens in the community who wanted better service, better experience, and better health outcomes, not siloed-based thinking with poor communication. People were actually dying.
And yet, Peter, you're saying all the right things, and yet you failed.
Yes.
System somehow. Let's talk about leadership next.
Well, yeah, that'll be the next topic. I still have. I'll move on to Shawn because I want to hear what he has to say about primary care.
Thanks, Denis. Yeah. I was actually hoping you'd skip me because I was going to really throw a spanner in the works and start some fireworks, because I think this is where I fundamentally disagree with both Ted and Peter, and maybe even yourself too, Denis. So I'm waiting for Peter to turn his microphone on mute so he doesn't cut me off as I'm going to talk. I'm just kidding. So for your audience, this is really crucial. We've heard two words used interchangeably, and they are opposite. We've heard ecosystem and system. An ecosystem is not a managerialized system. We've had all sorts of ideas thrown out. We need to tweak this and have primary care networks there and direct access here and change incentives and change. That presupposes managerialism applied to a system that is basically done from a centralized decision base. And whether you make the decision at the center of the province or you localize it into a bunch of regions, provinces do this all over, regionalize, centralize. It's still based on the presupposition that managers will do a better job. And if we increase the number of managers and increase the control of the managers, increase the ideas that the managers give us, we will get better care for patients.
Well, you captured why I used the word ecosystem. Thank you.
Yes. And so this is right where I was going to compliment Denis on this. He opened his remarks by saying ecosystem. An ecosystem in complexity theory describes a system that has more information than we can possibly know. One tiny change, you throw a drop of aspirin into your pond, you may create untold impacts. A little cyanide pill, you'll completely screw up your whole pond. And so if we view our sector of our economy, healthcare, it's a sector. It includes biotech, pharma, facilities, labs, multiple industries. And if you think of that sector, not a system, as an ecosystem, we would be much more humble about saying, oh my gosh, how do I know whether my little change of family healthcare teams or primary care networks are going to create a net benefit, or whether they're going to crush all the individual incentive that already exists? Are they going to leave a whole bunch of people without care? Are they going to create a culture where it's okay to say, you have a diaper, just go to the bathroom in your diaper? And we do not have that kind of humility when we're talking with the language of managerialism. And so I'll end with my second point. That was a long first point. My second point comes from James Q. Wilson's work on describing the different types of public organizations. Healthcare, I won't list the four because we don't have time, but healthcare is a coping organization. Just like education, just like peacekeeping. You can't always see the work being done, and you can't always measure the work that's been done. When a police officer is out on the beat, keeping the peace, can you pay them more if they keep more peace? Peace is a metaphysical concept. How can you tell how much peace has been kept? Peace is different at a bocce ball tournament than it is at a public concert. Same for education. How do you know the teacher actually educated that kid versus their friend in the seat next to them versus their grandpa that takes care of them at night? You get the idea. In a coping organization, by definition, according to the Harvard professor I just mentioned, you will have conflict between management and the operators within that organization, because the management will want to change a coping organization into a procedural organization. And a procedural organization is something where we can see the work, but we can't see the outcome. So you will create lists and protocols and measurements. Anything that matters must be measured. And, Peter Drucker and all that kind of stuff, and governance charts and org charts. And that will frustrate what we're trying to do, which is to provide care for patients. So healthcare is a whole practice, medicine in particular, aimed towards the betterment of patient health. As such, it is an infinite good. It's like seeing. You can never say you've got enough sight now. You don't need any more glasses, Perry. We're going to take those glasses away. Health is the same way. We can always make you healthier. We can always tell you ways to be better. And so we fundamentally misunderstand what it is we're talking about when we're talking about primary care. We think it's things that can be measured, hemoglobin A1Cs and blood pressures and stuff like that, and put into spreadsheets. It's not. Denis opened up. He said, we know our patients. It starts with a relationship. It's a coping organization, and it's an ecosystem. It is not a system. And I'll end with this. When we nationalized, or socialized is the old-fashioned word for it, when we nationalized our health insurance, medical insurance companies in the 1960s, we gave control of paying for medical care to the government. That's it. We nationalized the payment for care. Between the late 1960s and the 1980s, we transformed into managed care organizations. We now have multiple provincial health maintenance organizations. There was never a political debate about that. It was done out of necessity because governments were on the hook for having to pay for all this care. So that is the crux of the issue. We have government that has usurped control of management of healthcare. We've never had a debate about it. And yet we have all these people with all these ideas about how we need to redesign this and redesign that and redesign the next thing. And they're all great ideas. But there are too many great ideas and no one's able to actually go and enact anything. We have all these fancy people in government saying, well, we just need to do this because it worked at Intermountain and it worked in Australia and it worked there. And I've been one of those people. So I'm saying this as I'm guilty of this. I was 5 years chair of health policy at the OMA, signed off on many health policy papers. Well, we just need to do that. And we need to tweak this fee code and we need to tweak that fee code. I'm suggesting it's the wrong way to think about it. It's an ecosystem based on relationships within a coping organization. And that would radically change the way we think about primary care.
Yeah, that's a good point. Yeah. What I see in ecosystem, we understand that it's a little messy. You can't really measure everything about it. You got to let it go, sort of thing. And messy systems are hard to manage and hard to put up with. So I think that's the frustration for a lot of bureaucrats, is like they can't handle that little messiness, eh? So
Denny, that reminds me, I know you're going to get into leadership, so I'll help you get there.
Okay.
Mahatma Gandhi's leadership style was one of articulating a vision and getting out of the way.
Yeah.
The vision that Canada has is a payment system managed by the top. That's not really a vision anymore. That was the building of something. Well, it's been built. It's now time to have a vision that incorporates something about patient outcomes, as simple as waiting lists. That's a Gandhi model. Create a clear vision. We do not have a clear vision today. Create a clear vision and get the hell out of the way.
Yeah. And who better to exemplify leadership than someone like Gandhi? So, I think that's you touched on it, Shawn, about about, it's where's that leadership going to come from? That's going to lead to our last topic here. So we all agree that true leadership is essential. And I wonder, will it come by evolution or revolution? We've seen our share of healthcare commissions and ministerial reports and white papers, and we've been through changes of government, and yet here we still are. We haven't really, gone anywhere before. So I guess I'm asking each of you, where do you see that leadership come from? Where's it going to come from? I'll start with Peter.
Citizen-led revolution.
Fair. Yeah.
Next.
Next. Yeah. Shawn.
So you asked about incremental versus wholesale change. Do we tweak and fiddle, or do we disrupt, like Uber, or like laptops versus mainframe computers? I would throw this out to Perry. Perry said we need a clear vision. I would say we actually, for the most part, have a very clear vision. It's just rarely stated explicitly. Roy Romano, and I can read you the line. I'll grab the book off the shelf if you want. He talked about his 50 years defending Medicare, and he said, just to be clear, our fight is not over. We need to, quote, protect our great redistributive program we call Medicare, end quote. Our great redistributive program. So in the minds of Roy Romano, people like Roy Romano, our clear vision is to achieve redistribution of income, full stop. That's why we have our system. It's not patient care. And so to your point, Perry, we need to have a fundamental discussion about what it is we are trying to achieve. Are we trying to achieve life and limb care? Are we trying to attend to the fundamentals of trauma care and cancer care and bladder surgery? Or are we trying to win votes and redistribute income? And I think in the minds of the people who have the power to make decisions right now, it's about income redistribution. And let me be clear, income redistribution may be a wonderful thing, wonderful, but don't do it on the backs of patients. If you want to redistribute income, go for it. Create a program of redistribution, but don't trick everybody in the country into thinking that we're achieving redistribution by building Medicare.
Peter, quick word, I guess. Yeah.
Well, since I didn't take 4 minutes, I took all of 4 seconds. I've got a copy of this lovely report, which, hang on, the folks from Ontario should recognize. You make it, it's blurry, I'll read it. It's the Commission on Reform of Ontario's Public Service. And in this, there is an entire chapter on healthcare and what we should be doing with healthcare. And there's led by a Queen's professor whose name I'm gapping on right now, but you know who it is. Leadership needs to be from the bottom up. Shawn, many of you wouldn't know, Shawn and I have a history, so we're kind of poking each other here nicely about what works and what doesn't work. I will always be a values-based engineer, which means I respect measurement if it's the right measures. We have fundamental problems. The system, a fee-for-service system for physicians, does nothing but pay for process and outputs. It will never pay for outcomes and impact to societal gains. You could say that impact is impossible to achieve unless you're looking at it longitudinally and retrospectively, because you're not going to be able to draw a direct connection, which is Ted's otherwise way of saying complex adaptive systems. But at the end of the day, we can measure the relative status of the economy. We can measure the relative status of the culture and the community that we're in, but we're constantly bombarded in a good way with values from other parts of the world as our immigration policy starts to bring in other people from other parts of the world. So we cannot ignore that. We have to embrace that. And the healthcare system is not designed to account for that.
Mm-hmm.
So leadership has to be more inclusive. Leadership must be from the bottom up. The decisions that are made need to be distributed, But if I was going to summarize where I think there's alignment across the panel, is that we don't do enough to engage individuals in asking what is a great outcome for you. I can do X as a practitioner, but what is a great outcome for you? How can I help you in collaboration with what you're going to be accountable for when you leave my visibility of care to follow my advice based on what your constraints are in your life so that you get the best possible outcome as possible? Many of you may remember Greek mythology and the Cyclops. The Cyclops gave up one eye to have the eye of foresight, which is that they knew exactly when and how they would die so they could live the most fulfilling life. There is a project out of the Ottawa Hospital Research Institute that has a life expectancy calculator. And the way it works, and it's like 100 countries around the world are using this thing now. And it's basically based on your behavior in the last 10 days and based on your future goal. Mine happens to be to see my son's 50th birthday, healthy, which means I'll be 87. My mom's 86, so it's not impossible. Okay? But it's basically looking at the behavior that I have as an individual, and it's saying, what's the probability that I'll achieve that future goal? And it allows me as an individual to start to make choices, right? That may increase or decrease that percentage. Like that kind of preventative care or like what are the choices that I'm making on a daily basis, and knowing the risk and reward requires me to be educated, requires me to have a community around me to support me in the choices and making me accountable for that. And very little of this has to do with me interacting with my family doc, even though he's amazing and he thinks I need a rehab sports medicine doctor, not him. But, you know, like, these are all things that reflect leadership. So leadership as an individual, us as a society not being complicit in the way that the education system works, the social system works, right? And I love, Shawn, I love the comment you made about humility and humanity with managerialism. Right? You can't have one without the other. It has to be a values-based and evidence-informed thing.
Thank you. Ted.
I wrote down 6 categories of leaders to make a comment on. My categories are politicians, which you just named, ministers of health, for example. Public servants is my second category. Healthcare governing boards, chief executive officers, CEOs of healthcare organizations, senior and middle managers, and then the last one's 6, all the staff, physicians, and citizens. Okay, so let's start at the top. Politicians, and as you just pointed out, I was the chief of staff to 2 ministers of health, but I also was a policy speechwriter for 3 other ministers of health. And so what I ended up doing is I worked very, very closely with ministers of health from all 3 political parties in Ontario. What was common among them is that they were all progressive ministers who really wanted to make a difference, and they ran the ministry. Now, my comment is, we haven't had a minister like that in a long, long time in the province of Ontario. We have ministers who are script readers. They're, the scripts are prepared by the bureaucrats and the minister just reads them off, and they don't run the ministry. So until and unless we get political control of the system through a competent ministers of health, we're in trouble. Next, the public servants. And I'm not going to deal with a lot because people think I'm too tough on the civil servants, but I think that it's a fact that they have been extraordinarily self-serving. I'm not going to go into the details of, redirecting funds that were intended for mental health services and building centers of excellence and a whole new divisions of mental health. That's the kind of thing they do because they care more about themselves and they're self-serving and they can get away with it, particularly when they have weak ministers. Next, the healthcare governing boards. And I've worked as a governance coach. And most of our boards have no idea what their job is. The purpose of a governing board is to represent the interests of the owners of the facility, the institution, the hospital, or the service are the people of the province and the taxpayers. Those are the owners, and those governing boards are supposed to be operating in their interests, and they're not. They're simply led around by the nose by their CEOs and others, and so they do not stick up for those of us who own the facility. The CEOs, I don't know what it's like in Alberta, but we select our CEOs on narcissism. Our boards, they are narcissistic. We pay them way too much money, so that is their thing, is that they like to be the big guy in town. We don't have any humble or not many humble CEOs, and there's no accountability. Nobody utilizes best practice accountability agreements, methodologies, and boards. In fact, what's interesting is accountability has now been, the old world of accountability has now been shifted into instead of the annual meeting where we look at the accountabilities and the outcomes that the CEO achieved, we now have the bonus bingo meeting where we figure out, because the CEO showed up for work on most days that he or she was supposed to be there, they'll get their huge amount of bonuses, and so they're not being held accountable. Senior middle managers really need training. We don't invest in managerial training, and in particular, I wrote down the word stewardship, and stewardship is about being in service to rather than control of. So think about that. A CEO who's in service to the senior team, in service to the middle managers, in service to the front line, they're there to just remove barriers and supply the supports they need to be successful. We don't have that. We've got a top-down command and control hierarchy with narcissistic players. And the final one, and I'm throwing in the citizens along with frontline staff and physicians. That last group, physicians, staff, and citizens, really need to rise up. They are all the victims of a hierarchy that is screwing up this system, and we need a revolt, a bottom-up revolt. Not an armed insurrection, but certainly a revolution that's got to take place bottom up.
Thank you very much, Ted. So we'll ask one final question to each of them. And in 1 minute, I would like you each to share one clear sign of hope and optimism that you have that gives us some hope for some meaningful healthcare reform. So if there's one clear sign that you can share with us, I'll start with Shawn.
So every day from coast to coast, in every hospital, every clinic, but especially in hospitals, doctors and nurses from minute to minute are working around the system to find care for their patients. They're finding creative solutions. They're finding workarounds. Discharge planners are finding creative ways to get people home where they want to be, to get them the services they need by calling a neighbor, calling a friend. And so I have a great deal of hope if we could just let these people go, unleash them. They're already doing it. Let's make it a little easier for them to do what they want to do, which is provide care for people.
Good. Thank you. Peter.
One of the boards that I'm on is Imagine Citizens Network. It's Alberta based, but it's been able to do a number of things since it was originally formed in 2014 around listening to the voice of citizens and what matters most, what outcomes matter most to individuals. And that has helped guide different parts of how care is provided. It's helped individuals navigate the healthcare system better because it's very confusing here. We've worked in collaboration with different agencies in order to make that happen, including Alberta Health Services. But where we're at today, as a respected voice across Canada, we're missing is a volume of communication and listening on the front line. And so what we're in the process of doing is raising funds in order to bring care with a platform that's leveraged in the UK, in the NHS in Scotland, and the NHS in England, for looking at more meaningful engagement with citizens at the front line of care. And the problem that we have in Alberta, as well as in other parts of Canada, is that that listening exercise is often documented either by the individual staff member, usually by the individual staff member, to what's called a learning management system, an LMS. And AHS has about 750,000 data points. This is data, I'll timestamp it to 2017, of episodes of improvement that go into that learning management system, and including what happens when they engage with a patient or family member, but very little of it is used to improve or innovate against. And so what the UK has been able to do is actually engage in a third-party platform that facilitates dialogue directly between patients and family members and various care providers to allow for direct and indirect communication. One of the beautiful things that's happened from that is the gratitude that doesn't often happen enough for that frontline staff to hear. They hear thank you in the moment, but there's thank you afterwards. And it also allows for curiosity, and in a calm way to allow for patients and family members to provide feedback so that it's not met with tension.
Yeah.
It sometimes can be in the workplace, but it allows the individuals to be thoughtful about that. So that's a really exciting way of improving communications on the front line, which might actually help.
Okay, thank you. Ted, what is one clear sign that that gives you some hope and optimism?
I'm sorry to confess, I don't have a lot of hope and optimism. Although I see hidden inside the collapsing of our current system is possibly the turnaround that we need, that everybody's had it. I've had the rare opportunity of being a consultant for the last 25 years, and I've ended up working with extraordinarily good CEOs. We would show them the methodology we're going to bring, and the methodology fails 70% of the time. And we'd sit down with the CEO and explain what's going to happen here, blah blah blah, and then give them the fair warning that this only works like 30% of the time. It was the most courageous ones that pushed the button and went for transformation, which is that process that from a caterpillar to a butterfly, right? The DNA in the caterpillar and the DNA are in the butterfly. It's the same animal, it's the same beast, but it's transformed. That's what they can do with the healthcare system. That's what you can do with the hospital. And the courageous CEOs who had it were prepared to do the courageous, outrageous thing. So there are little pockets, and I'm going to say 30% of health CEO of CEOs probably are prepared to be that innovative, but 70% are not. So I'm not optimistic. I'm not optimistic that our politicians we're going to start getting good politicians. I'm not optimistic that our public servants are going to stop being self-serving. But where do I think the explosion is coming, where there could be a turnaround? Politics at election time. People are getting very aggravated at all the stories they hear from their family members and their neighbors that this is a system in serious collapse and requiring massive restructuring and redesign. And I don't believe more money. 30% of everything we do in our $81 billion healthcare system in Ontario is wasted or unleveraged spending. So we do not need more money. We need to redistribute the wasted money to buy the things we actually need.
Okay. Well, thank you, Ted. I think it is a sobering thought. That was my attempt to try to end on a positive note. Let's just say that your glass is 30% full. So,
maybe, yeah.
Okay. Well, Thank you to our panelists. Thank you to Shawn Whatley, Peter Fenwick, and Ted Ball. This was our attempt to cover a vast question and to come up with some type of something to further a discussion. So I guess I'd like to thank Perry for hosting this, and thank you for the others in your network for inviting us to participate in this. Our question, I guess, as panelists, our question is to you, Perry, is like, where does this go next?
Well, let me interrupt and say thank you, Denny. Thank you for the time you spent the last couple of months. After we had a glass of wine and talked about this event, we're now drawing it to a close. And thank you, Shawn. Didn't know you a month ago. Know you much better. Peter, of course, and Ted, for your almost a refreshing wrap up there, Ted. But Denny, personally, thank you very, very much. Nobody really gets the closing word on this. We are in a period of transition. We are seeing resistance to change coming from the extraordinary powers that exist to maintain the status quo that come from unions, though they may be made up of caring professions that don't seem to have adequate influence to get the union to incorporate into its negotiation the relevance of the patient. Their job is to ensure the relevance of the supplier. We have a government that is established and maintaining a health system for redistribution. It's about supply. We as a nation should be proud of what we've built, but we haven't finished the job. And I think this discussion today is about the next phase, and a critically important phase of finding adequate power needs to be in the hands of the consumer. And today the power is all about supply, the jobs and the money. We don't have the metrics, but we do have the mindset, but we don't have the power. And so I ask, who will be the advocate for the patient in negotiations in this transition? It has to come from the bottom up, because it's certainly not there at the top, even though we are in a democracy. I would love to believe that this will occur through evolution, and I don't think it will. I think there's been too much time and effort spent to this point. It's going to have to come by those frustrated by sitting on waiting lists, and those who believe that technology is headed in the right direction of personalizing their involvement in their healthcare. I am optimistic, just by the sheer fact of what I was hearing today. How could you be anything other than optimistic that a frustrated patient is going to go to Mexico, is going to fly to Quebec, is going to move around and find a new doctor or find a piece of technology? We have people today that are feeling more and more empowered to ensure that their interests are taken care of. And I think that is going to be a challenge to every professional. Their relational skills will be critical, and every politician should wake up. So thank you, Shawn. Thank you, Peter. Thank you, Ted. Thank you, Denny. And thank you, audience.